Hello, everyone, and welcome to today's webinar on the Healthcare Cost Institute's 2016 Healthcare Cost and Utilization Report. Before we get started, I would like to go over a few items so you know how to participate in today's event. Next slide, please. If you have joined the presentation using the computer's speaker system by default for audio, if you would prefer to join over telephone, just select the phone in the audio pane in your attendee control panel to the right of your screen, and the dial-in information will be displayed. If using this option, please enter your PIN number displayed on the screen. You will have the opportunity to submit questions by typing your question into the question pane of the control panel. You may send in your questions at any time during the presentation. We will collect these questions and address them during the Q&A session at the end of the presentation. Today's webinar is being recorded. A link to the recording will be made available on the HCCI website. Next slide, please. I would now like to introduce today's presenter, Niall Brennan. Niall was appointed President and Executive Director of the Healthcare Cost Institute in June 2017. In this role, he is responsible for overseeing HCCI's advancement in price transparency and public reporting, increasing both the comprehensiveness and access to HCCI's expansive data set, as well as working with state policy and decision makers to improve their healthcare systems. He is a nationally recognized expert in healthcare policy, the use of healthcare data to enable and accelerate health system change, and data transparency. Prior to joining HCCI, Mr. Brennan was Chief Data Officer at the Centers for Medicare and Medicaid Services. Niall?
Thank you very much. It's a pleasure to be here and work through our report with folks. Before I get started going through some of the findings, I want to thank and acknowledge the report authors, Amanda Frost, John Hargreaves, and Sally Rodriguez. I think they've done a fabulous job with the report this year. We wanted to place a strong emphasis on appealing and intuitive data visualizations, and based on the media and social media reaction, I think that we have achieved this goal. Next slide, please. So I want to go over some of the high-level takeaways from the report. We find that total spending per person is accelerating among the employer-sponsored insured population. In 2016, growth was 4.6% compared to 4.1% in 2015, and sub 3% growth in 2012 and 2013 and 2014, excuse me. When we calculate a 5-year cumulative spending growth, it was 15%. And as you'll see in many subsequent slides, we attribute almost all of this spending growth to price increases, not to increases in utilization. We saw particularly large increases in spending and prices for administered drugs, ER visits, and surgical hospital admissions. On the consumer side, out-of-pocket spending also increased, but interestingly, it increased more slowly than total spending. So out-of-pocket spending as a share of total spending actually declined. However, you all understand, as do we, that out-of-pocket spending is just one component of consumer exposure to healthcare costs, and they may be facing this exposure through higher premiums or reduced benefits, or both. One final note, next slide, please. I'm also very happy to announce that all of the data underlying this report has been made available both in Excel spreadsheets and, for the uber nerdy among you, a machine-readable data set that you can directly read into the statistical analysis software of your choice and analyze it to your heart's content. Please download and use that data. So the next slide, the slide that we're on, just so I don't confuse anybody, I'm sorry, yeah, that's my fault. This subdivides total spending into 4 major categories, and then we further subdivide it into 35 subcategories. And so you can see that total spending per person in 2016, again, this is a non-elderly working population plus their dependents, was $5,407 and splits out according to the chart on the right, $1,000 for inpatient, almost $2,000 for professional services, $1,500 for outpatient services, and $1,000 for prescription drugs. If you look at the chart on the left, you can see that in general, spending did tick up in 2016, as reflected in the overall 4.6% number. The growth in prescription drug spending was actually down fairly significantly to only 5.1%, but I use the word only advisedly because the previous year featured double-digit prescription drug spending growth, and in 2014 it was almost 8%. Next slide, please. For me, this is one of the more compelling findings and visuals from the report. We have decomposed overall spending into a price effect and a utilization effect for each type of spending. As I've said, on the right-hand side, you can see the overall spending grew by 15% over a 5-year period, ranging from a low of 8% for inpatient spending to a high of 27.2% for prescription drug spending. If you then cast your attention to the left-hand side of the chart, you can see that all this happened at a time when working Americans were actually using the same, or in most cases, less healthcare over this 5-year period. So, but prices were increasing significantly, which led to the overall healthcare spending growth. Next slide, please. So I'm basically going to march you all through each sector of spending, inpatient, outpatient, professional services, prescription drugs, and brand drugs, and then finish up with some information on out-of-pocket spending trends. So again, the beauty of our data is that we can subcategorize large spending categories like inpatient into, in this case, 5 high-level categories of service: surgery, labor and delivery, newborns, mental health services, and medical. And again, you can see that the overall story on inpatient spending is repeated here, even as you get more granular with the types of inpatient spending that's going on. So you can see that, for example, utilization of surgery in inpatient hospital settings declined by 16% between 2012 and 2016, but prices increased by 30% for an overall price increase of 9%. So an overall spending increase of 9%, my apologies. You can see rather larger spending increases for some other categories of inpatient care, particularly mental health services. It is a large increase, but if you look at the very bottom of the slide, you can also see that mental health services constitute only 4% of inpatient spending overall. So even though it was a large increase, its impact on overall hospital spending was somewhat limited. Next slide, please. So moving on to outpatient spending trends, again, to perhaps give you an idea of the relative proportions we're talking about, please look at the very bottom of the slide. So you can see that overall outpatient spending, 37% was accounted for by surgery, 23% by emergency room usage, 13% by radiology, and then we have a couple of cats and dogs. Again, once again, the overall story is largely the same. Outpatient utilization essentially flat or declining. There are small increases in utilization for emergency room services, but then you can also see the much steeper slope increases for outpatient prices, which leads to the finding that spending on emergency room services increased by 34% between 2012 and 2016. Next slide, please. Professional services was our next area of analysis. This particular category had the lowest overall growth in 2016. It was only 3.5%. It is also the most granular data, if you will. So while John's visualizations are absolutely fantastic, having so many subcategories it does make it somewhat challenging to interpret, but you can also see that the trends that really stand out here are significant, very significant price increases for administered drugs, and very significant utilization increases for primary care office visits. This is actually something that we delve into in a little more detail in our annual report. It's going to be a major area of research focus for us in the early part of 2018. We were surprised at the decline in primary care physician visit utilization. We also noticed a corresponding substitution effect where as PCP, you can't see this in the visuals on this slide, but as PCP utilization declined, specialist utilization increased. So there definitely seems to be something going on there that's worth exploring. Next slide, please. So now we're going to look at brand prescription drug trends. Obviously, prescription drug spending and growth in prescription drug spending has been highly prevalent in a lot of discussions over the past few years. Just so you can all understand, brand prescription drug spending in our population still represents 75% of all drug spending. So while generic utilization is increasing, the majority of the dollars are still accounted for by brand name drugs. Obviously, some of these trends, I'm looking particularly at the, we'll call that green anti-infective line, are driven significantly by the introduction of hepatitis C drugs, which we all know are very expensive, but have also had a transformative effect on the health and long-term health outcomes of individuals with hepatitis C. We also saw stunning growth really across all categories, broad categories of brand prescription drugs. So utilization, which we measure as fill days per person, was down by double digits across the board, and price was up by high double and in some cases triple digits between 2012 and 2016. Next slide, please. So let's have a quick look at generic prescription drug trends. What we generally are seeing here is utilization increases with a couple of small exceptions, and flat or declining prices, again with a few small exceptions. For example, on anti-infectives, on the generic side, utilization is actually down by 4%, but over the 5-year period, but prices are up by 6%. We call this our Pac-Man slide internally, and so you can see that the jaws are very large for respiratory drugs, with a 121% increase in utilization and a 55% decrease in price. We believe, although again, once we start analyzing the data even further, that this is largely driven by Singulair coming onto the market as a generic at a significantly lower price. Next slide, please. And then we just wanted to have another kind of look at brand prescription drug spending and generic spending together. So focusing on the average price for 30 fill days, and then the specific growth rate in 2016. So you can see for anti-infectives, there was actually a small price decline. We theorize, and other people have informally validated, that that's likely due to a moderation in pricing for hepatitis C drugs. But you can also see that for many other drug categories, there were still significant year-on-year increases. Stating the obvious here, even a small decrease in a price for by far the most expensive drug class on the market can definitely move the needle on overall prescription drug spending inflation. So we're almost wrapping up here. Next slide, please. We wanted to talk a little bit about out-of-pocket spending trends, both in general and specifically on prescription drugs. One thing is that the distribution or mix of what people spend on out-of-pocket services is different from total spending. So you guys can compare those two corresponding charts sort of at the very start and very beginning of our report. We don't have them side by side. But you can see that in particular, what's happening is while out-of-pocket spending is increasing, out-of-pocket spending is increasing at a slower or lower rate than total spending. So out-of-pocket spending as a share of total spending is declining. Again, as I've said before, that should not be interpreted as a sign that these are the glory days for U.S. healthcare consumers. I think everybody realizes that consumers can be affected in many ways by healthcare inflation, particularly in the form of rising premiums and reduced benefit packages. Now, what is noticeable is the decline in out-of-pocket spending per person on prescription drugs. Next slide, please. And you can see that there was a relatively significant decline in out-of-pocket spending for brand prescription drugs, and a more modest decline for generic drugs. We think this may be for a couple of reasons. It could be the impact of coupons. I also know that in consultation with some actuarial advice that we've received on our results, that people feel like the combination of medical and separate medical and drug deductibles into a single overall deductible may have had an influence on what people are paying overall out of pocket. So next slide, please. For us, these are the key takeaways. I don't know if it quite qualifies as a haiku, but it's pretty close. People spent more and used less because prices went up a lot. And we will be happy to answer any questions that you may have on the webinar. And you also know where to find HCCI and me in general on Twitter. We're very excited with the engagement and the interest in this report. I think 2018 is shaping up to be a very interesting year. We have a very full research agenda, and we want to share our insights with as many people as possible. So I appreciate your time, and then just once again want to thank Amanda, Sally, and John for their excellent work on this publication.
Thank you, Niall. So as a reminder, you can still submit questions through the question pane in your attendee control panel. We have a few questions in the queue. First, do these changes in prices impact consumers?
Undoubtedly, I think the impact consumers in many different ways. Somebody's got to pay for this. So I think a lot of the discussion around rising premiums in recent years definitely implicates these price increases and their impact on consumers. I also think that increased consolidation in the provider market may be driving some of these price increases. Obviously, that's something we want to look at in more detail to see if we can draw a definitive link.
One question, is there an association between the visits to primary care and those to specialists? You alluded to it in your remarks.
Yeah, I alluded to that earlier, and again, this was for me personally one of the more fascinating findings. I want to make it very clear, we don't have any definitive conclusions yet. We're making it a priority to dig in. I think from a general hypothesis-driven structure, we are kicking around the following ideas. Idea number one is, if you look very carefully at the chart in the report, not the slides, but the chart in the report, you can see that preventive visits to both PCPs and specialists increased modestly. And we think one of the reasons they increased modestly is that preventive care was rendered essentially free under the Affordable Care Act. So further to that, we think what might be happening is that if people go to a specialist for a free preventive care visit, that can then lead to a sequence of follow-up specialist visits, whereas it's possible on the primary care side, a preventive care visit may just be substituting for primary care that would have happened anyway. That being said, it doesn't fully explain the decline in the overall decline in preventive care visits. Some other hypotheses were wondering if there may be a minute clinic phenomenon, to the extent that there being things that were previously categorized as primary care visits are being picked up or coded, possibly in the outpatient department. So then we're also going to, just kind of look at the math. So we want to see if the number of unique physicians billing, the number of unique primary care physicians billing in our 2016 data is less than the number of unique physicians billing in preceding years, because if that is the case, it may have implications regarding access to primary care and perhaps people choosing to see specialists instead.
Thank you. Why are the prices for brand prescription drugs and hospital surgeries rising, even though insured are using less healthcare? Shouldn't the prices go down when demand also declines?
Well, I'm not sure that common sense necessarily applies in a lot of discussions about healthcare pricing. I've been doing healthcare policy and analysis for probably longer than I'd like to admit, and one of the older analogies I've heard, characterizes healthcare spending as akin to a balloon. So when you push in on one part of the balloon, it tends to expand elsewhere. I don't have definitive conclusions. I've alluded to the fact that increased consolidation may be increasing provider bargaining power with private payers. It's possible that it's also a response to pressures in other aspects of their business.
Okay. What's going on with the price of surgery?
Well, it's going up at a time when utilization is going down. Again, we're not 100% sure what's going on. The numbers are really striking. I believe the average cost of an inpatient surgery is now over $40,000, and that's an increase of $10,000 over a 5-year period. So Again, we'll be looking at this in more detail. Our initial results suggest that there is not a strong case mix effect, and so that this result, when we decompose by major diagnostic categories, and obviously we'll ultimately get down to the DRG level, we're finding that the utilization declines are pretty consistent across all major diagnostic categories, and the price increases are pretty consistent across all major diagnostic categories.
Given the full employment and the recent fiscal stimulus, do you see medical trend increasing? Would you expect to see both utilization and price increases?
So here's where I'd probably defer to my friends and former colleagues in the Office of the Actuary at CMS. If you look at their National Health Expenditure publication that was released just before Christmas, they definitely see healthcare spending continuing to rise. I believe they project that it will increase from 17.9% of GDP in 2016 to 19.5% of GDP in 2025. So that's a pretty significant increase. And they also infer that they believe that almost all of the increase in spending growth will be driven by price and not utilization.
Do your branded drug prices and spending data reflect discounts provided to the payers by industry?
They don't.
And can you remind everyone of the source of the data?
Oh, so this is data from United Healthcare, Humana, Aetna, and Kaiser. We received this data in partnership with those organizations. It's approximately 40 million unique individuals each year. So it's a very significant portion of the ESI population. It's a very significant amount of healthcare dollars, and we have also weighted our results in the population to be representative of the overall population with employer-sponsored insurance.
When you look at the national health expenditures, it seems like overall health service prices increases have been quite moderate. Do your results reflect the growing gap between commercial and public provider reimbursement?
I think they could. You know, obviously, Medicare and Medicaid have more discretion to draw a harder line on price, and it seems like that harder line has not been able to be drawn for folks with private sector health insurance.
Could the primary care provider acquisition by hospitals and hospital billing explain some of the decline there? It
also could. It's something we want to look at. We know that has been a very prevalent practice in recent years. I would say in general, another area of interest for us this year is going to be very closely analyzing primary care providers and whether they are in smaller solo practices or have been are in larger groups that have been acquired by hospital systems.
Is there significant differences between Kaiser and the other commercial payers in your findings, especially as you add the Kaiser data this year?
The shortest answer is no. We did it's not a pre-post is not a good description for it, but we basically analyzed the trends with and without Kaiser data over the 5-year period, and did not find the introduction of Kaiser data as substantially biasing our results.
And then on drug pricing, what is the price reflected in the data? Isn't the detailed prices paid to pharmacy, so full net, but not the list price either?
I'm going to have Amanda answer that question, given that she knows a lot more than me.
That's right. What's in the data is the actual amount that was paid for the drug to the pharmacy, which would not necessarily be the same as the list price for the drug, not including any rebates or coupons or discounts.
Okay. And there are quite a few questions about the use of the data and specific details about that. We will be addressing those via email, so be sure to look out for an email from one of the researchers here at HCCI for specific details about your questions. Okay.
I would add that, you know, I've already alluded to the fact that we've made the data available in Excel and machine readable format. For folks for whom that is not enough, we recently launched an open access data model for our granular statistically de-identified claims data, which is hosted for us by the National Opinion Research Center in Chicago. And so that now means that any academic from any university in the United States can apply to get access to the granular level claims data. We have about 32 research teams in there right now, and we're certainly hoping to grow that number over the course of the year.
Are you seeing any impact of the opioid epidemic in your data?
We didn't specifically look at the opioid epidemic in the context of the annual report. However, we share everybody's concern of the devastating impacts of the opioid epidemic on American lives and the American economy. We recently hired an opioid expert from the Centers for Disease Control, and that is obviously going to be her research priority for this year. I direct folks to our newly launched HCCI blog, where I think the first tangible example of our engagement on this issue is available. We did a county level analysis of chronic opioid dependency and found that in certain low-income counties, as many as 1 in 5 working Americans were classified as being chronically addicted to opioids. So that is hugely troubling and obviously has again serious implications for you know, productivity and general quality of life in those areas.
Any additional detail as to what specific subcategories are driving the cost of the skin drug category?
So we'll know more about that over the course of the year. I think in general, we think it may be driven a little bit by Humira and other biologics. You know, I know when I watch television, I see a lot of ads focused on people with psoriasis, for example. So we think that might be at least partly to explain some of this growth.
You spoke to the association between primary care and specialists. Was there an association between primary care visits and ER visits?
We haven't looked at that yet, but we certainly will.
And are minute clinic or other urgent care data included in the report?
They are included in the data. We sort of don't have a good handle on exactly where. That's kind of going to be a methodological priority for us this year, because I think it's going to help us. One of the results we didn't talk about was a fairly significant decline in emergency department usage among children. So it's just a question of figuring out where those claims end up hitting the system. Is an outpatient claim? Is it a professional claim? We have been looking at this, and unfortunately, at least in our data, you know, the claims don't come in with a little asterisk saying this happened at a minute clinic. So we may have to figure out a proxy for those services.
Okay. And have the drug prices started to stabilize after that sharp increase in 2015?
I don't think that you can say drug prices have started to stabilize. If we want to go back 1 or 2 slides, I don't know if this is going to mess up our ACE webinar team. Go back one more. To me, that doesn't suggest a stabilization in drug prices. What it suggests is continued increases across most categories that were offset by a decrease in a extremely expensive category of drug.
Okay. And our last question, what is the most important takeaway about healthcare and healthcare spending from this report?
Well, for me, it was that working Americans are using the same or less care and paying significantly more. I think that has huge implications for the healthcare system, for the overall stability and growth in our economy as a whole. And I think that we would probably behoove ourselves to talk more about why prices and spending are so high in American healthcare. So listen, thank you very much, everybody. It's been a pleasure presenting the results. Please continue to selfishly share the report with your friends and colleagues. Interact with us on social media or contact us directly. We're very passionate about this, and we like dialogue. So thank you very much.
This concludes today's webinar. As a reminder, any questions asked during the webinar will be addressed via email after the webinar. A recording will be available through HCCI's website in the coming days. And on behalf of HCCI, thank you for joining us today and have a great day.